and thank you very much for taking time out of your schedule to meet the public.
Thank you so much, Danny, and I hope everyone can hear me okay. Let me know if I'm coming through too strongly. Thank you to the Health Issues Centre for the invitation and the opportunity to say a few words and mostly listen and try and respond to questions. I'd also like to acknowledge the traditional owners of the land on which we're all meeting, the peoples of the land of the people of the Kulin Nations and beyond, and pay my respects to elders past, present and emerging. I do have a screen I'd like to share if I can manage it. I will work on that. Let's see what's coming up. Or I will just speak to it regardless. Let's see. I did want to mostly take time to respond to questions, so I'll be brief, and I won't share the screen, but I will use it as my speaking notes. So we all know that COVID-19 is a highly infectious disease that causes a really significant respiratory and multi-organ infection. It is not like normal flu. It is 10 or more times as deadly, and we've needed to respond to it by virtue of the severity of it and the fact that it's got pandemic potential and has become a pandemic. I think we made lots of assumptions about treating it a bit like pandemic flu, but our approaches have rapidly changed in the early stages of this pandemic because of the extraordinary severity of the illness. It really is like a worst case scenario for pandemic flu, akin to Spanish flu. We do have different tools nowadays, but we also have different lessons learned from previous pandemics. And I think what we've recognised is that this can actually be stopped in a way that is probably not possible for flu, and not every country has been successful in that regard, but the lessons are that it is within our grasp to keep transmission down to very low levels, and that's critically important with something that kills between 1.5% of all of those who get infected, and with a virus where one infected individual typically infects 2.5 in the next generation of infection if it's not mitigated by the kind of interventions that we're all trying to put into place. We know that those most at risk are the most vulnerable in society, the elderly, people who have pre-existing medical conditions, and Indigenous people around the world, including Aboriginal and Torres Strait Islander people in Australia, obviously. Victoria is now at around 1,700 cases. We saw a kind of sporadic seeding in Victoria from international travellers into the state in late January right through February in small numbers, and then a really rapid uptick in March where we got up to over 100 cases per day towards late March. And then there were a number of interventions, and I think it's important to reflect upon the fact that it was the combination of these that were required and that have done the job. The first one was the travel restriction that gave us the time and space to be able to respond from a isolation and contact tracing point of view. But then all of the physical distancing restrictions that came in various stages, the mass gatherings ending, the limitation on of 500 for those indoors and out, then stage 2 and stage 3 restrictions in Victoria. That drove cases down pretty quickly, where we got to a point by late April where we would see very few, if any, cases. Nonetheless, we've had lessons from clusters and outbreaks subsequent to that, where the explosive potential of the virus is apparent, where people are kind of forced into close contact. Then dozens and dozens of people can become infected in a very short period of time, akin to what we had seen intimated on cruise ships. Nonetheless, most of our cases have been through international travel and their close contacts, and we've had very low levels of those where there's been an unknown source in Australia. The measures for all of those cases, nonetheless, are really of isolation and quarantine of close contacts. Now that there's mandatory quarantine in hotels for international travellers, that risk is relatively easily mitigated, although it's a tough gig to spend 2 weeks in a hotel. But all of those other community cases is rapid and early identification and response, isolation of those cases so they don't infect anyone else, and identification and quarantining of their close contacts. That's what we'll need to do ongoing. And so we've got a pretty robust testing program to make it as easy as possible for people to access testing, to try and keep our testing levels as high as possible. There's sewage surveillance, and all of this has allowed us to now go through in reverse order the easing of restrictions in a precautionary way, still with a downward pressure on transmission. That's what we've modelled, and that's what we're trying to achieve, not to tip it into exponential growth again, but to have a slow and steady decay in case numbers over time. We are still seeing clusters and outbreaks. I think we will continue to see clusters and outbreaks until we can get to such low levels of community transmission that we effectively end all chains of transmission, and then whatever remaining clusters get managed to the point where people have recovered and there are no further contacts. That seems to have happened in the western half of Australia and the smaller jurisdictions. They were less seeded in the beginning than Victoria and New South Wales, and so they've been able to get to that effective elimination earlier than we have. But I'm hoping that we're still on that trajectory. New South Wales is very close. They might have had a few community cases, or at least identification of recent historical community cases in the last few days, but otherwise have gotten down to very low levels. We're still seeing a few cases every day in Victoria, but the overall trajectory is still pretty positive, and that's certainly the intent to manage. It is an impossible dilemma, understanding that the restrictions are required to manage the potential catastrophic risk of huge numbers of people being infected. It's been modelled up to 50,000 cases per day, tens of thousands of deaths in Victoria, against the known harms of the economic consequences, the individual, personal, physical, psychological, spiritual consequences for people as they've been isolated, especially through the most stringent application of physical distancing measures where people were effectively confined to home. And we know the consequences with respect to mental health, physical and interpersonal violence, and so that's a delicate balancing act. It's impossible to know that you've got the right path through it, but we're doing our very best to try and understand that we're lifting sufficiently to manage people's well-being and the economic well-being that supports that, without leading to an increase in cases. But I want to leave time to respond to questions. Thank you so much.
Thanks, Brett. And I will take questions. There's only a couple that have appeared so far in the chat room, so don't be shy, but I'm going to take host's privilege of asking the first question myself. I guess, Brett, one of the things I struggle getting my head around is what seems to me to be the inherent contradictions or the wicked problem of kickstarting an economy while we're relying on social restrictions to maintain safety. And clearly, our economy is predicated on the notion of high volume turnover, whether you look at the entertainment, hospitality or tourism industry. Pubs don't make profits by serving 5 beers a night. Restaurants don't survive by having 10 people or 20 people in a restaurant. So as we loosen social restrictions in order to drive profitability in those sorts of industries, what happens to those people who are vulnerable and potentially cohabiting with people who are increasingly engaging socially, whether it's in entertainment venues, work or public transport? How do you manage both those two? I mean, the data from the UK suggests that predominantly the riskiest place to be in terms of infection rates is at home. Most infections occur within the house. So where you've got multiple dwelling households, where you've got people who are highly vulnerable, living with people who are returning to normality. How does that play out?
Thanks, Danny. It is a genuinely wicked problem. You're right that the constraints that we still have in place really limit some economic activity. You don't have the foot traffic. You don't want the full foot traffic in the CBD because of what it means in terms of the interactions that people will have, but you want to be able to kickstart enough. I think people are being creative, and there are drivers to obviously have some of the economic generation through the takeaway, through all of the application of the hygiene measures, the messaging about not having ill people turn up, and to make sure that the information is captured to follow up anyone who might come in who. There are creative ways that people are trying to have ongoing economic activity without having the sit down or the foot traffic that's involved. I'm not the expert in that area, but I know that obviously there are drivers for people to try and find other ways for that. In terms of protecting the most vulnerable, you're right, transmission happens in indoor spaces with prolonged contact, and so households need to be absolutely cognizant about who's going out and being potentially exposed. I think there are lessons from Europe and North America that the most vulnerable in society, the elderly over 65s with chronic illness over 70s, and the other groups I mentioned, are not easily shielded when you've got very widespread community transmission, and the protection for them is not through shielding alone per se. It's not for them to just exclude themselves from civil society, but it's for all of us to do the right thing in terms of getting transmission down to very low levels. And so I think that's the way to manage all of those who are in aged care, all of those who are the most vulnerable to severe disease and to dying, recognising that at an individual level, they may want to take some additional individual precautions, and so we want to empower them with the knowledge about keeping that 1.5 metre distance, to make sure that they're checking that whoever's visiting them is not unwell, and to really manage the individual risk for themselves at a point that they're comfortable, knowing that there's a trade-off as well in terms of loneliness, in terms of social connection, but also to give them other mechanisms to stay connected and stay supported.
Okay, we're now getting a flood of questions, so I'll try to get through as many of those as possible. One question, what extra measures, if anything, do you recommend for those that are at high risk? So I guess that's a segue from what you were just saying.
Yeah, it is. I think the question of masks has definitely come up. WHO have made a statement recently about recommending masks in places where social distancing is not possible. We're not at a level of community transmission in Australia where that would be a recommendation, I think, nationally or from me. But I do think that people need to be individually empowered to have that additional assurance if they want to, if they know that they're going into a place where they can't physically distance, whether it's public transport or some other crowded area. And so while it won't be a recommendation for all of society, because WHO are talking about it for areas of high community transmission, it might be a consideration where we wouldn't stand in the way of people choosing that for themselves.
Okay, so that answers the next question, which was why masks aren't being recommended. And I do notice, Brett, that the US Academy of Science has just released a report suggesting that the evidence suggests that masks are more effective than social distancing in terms of minimising contagion.
Yeah, look, they probably do a bit of both. There's evidence that people stand further away from those who are wearing a mask. So it kind of does the job, and it's not a false assurance, as it were. People have expressed concern that those who wear masks aren't doing the other appropriate things. Well, they're probably sustaining their physical distancing by virtue of wearing a mask. But the US has states now where 1 in 5 people who are tested are turning up positive. There is extraordinary community transmission in some areas, and we're at a point where maybe 1 in 100,000 people in Victoria and less than that in other jurisdictions in Australia have the virus. And so there is a cost involved, and it's not clear that that should be a recommendation at a community level at the point in the epidemic that we're at now.
Okay, some people with high physical needs attend day programs that they use as a base. Whoops, it's disappeared. Use as a base to access the community. Most of these haven't reopened and are often have buildings too small for distancing. These clients have been home with limited supports. what's being done to support this area?
Yeah, it's not my specific area. Obviously, we give recommendations about how best to protect individuals, but the disability services area of Health and Human Services are trying to manage within those constraints as best they can. There's obviously been a gradual withdrawal of face-to-face services and now returning to it, and so managing some of the supports without having that very close physical distancing has been part of the risk mitigation, understanding the vulnerability of those individuals. But you're absolutely right that there are some constraints and some needs that really require close physical contact. So there has to be that absolute awareness about illness and signs of illness and self-exclusion, fastidious cough etiquette and fastidious hand hygiene. And for some circumstances, again, the choice of masks may be appropriate for individuals if they want that additional level of assurance of protection.
Okay, lots of questions. Brett has mentioned the success of WA in effectively eliminating COVID in the community here. We're facing huge pressure from the rest of our country to open our borders to boost their economies. Will the medical officers of other states such as yours support the WA government's stance of keeping our borders closed until states such as Victoria and New South Wales have also eliminated community transmission?
Yeah, look, I guess our international borders are a Commonwealth responsibility. They have made the call on, level 4 restrictions for outbound travel and everyone coming in to be in mandatory quarantine. I think that will remain. That would be the recommendation of AHPPC at the point we're at. We're trying to find other modes of quarantine that could support a greater number of people coming into Australia, whether it's a PCR test on day 3 or day 5, where you pick up almost all cases that would go on to develop disease, and if they're negative, to complete their quarantine at home. So a kind of risk stratification. There's obviously the idea of a bubble with New Zealand and maybe some of the Western Pacific. There should be consideration about countries where there's low to negligible transmission, and again having a risk stratified entry into the country with quarantine arrangements, but maybe not mandatory hotel quarantine in the same way. But I think we absolutely have to be mindful of the fact that if we get to effective elimination in the country, then we've got to be really stringent about the risk of importation of cases that then become new chains of community transmission where the constraints of physical distancing aren't in place anymore because they've been lifted, pretty substantially across a lot of Australia.
So Brett, just on that, I notice a lot of statements from our leaders emphasise the fact that we're aiming for containment, not elimination. But you just, I think, raised the potential of elimination. Is that on the is that under consideration?
Look, I think it's for National Cabinet to set that strategy. Both options were provided. I think they considered what it would mean to be under a stronger lockdown for a longer period of time, to have that absolute assurance. And they've talked about a strategy of suppression rather than elimination, and maybe in recognition of the fact that quarantine can always be breached by those in hotel quarantine, by maritime crew, by chronic shedders, by some kind of environmental contamination that then kicks off again. So there's a trade-off in choosing an elimination pathway. I would not be unhappy if we got there by a happy accident, and we're able to lift some of the constraints that we have much more fully, as New Zealand has done. Although I would say it's a pretty brave step for New Zealand to have effectively said no constraints whatsoever, hugs, kisses, no physical distancing. If there's a single individual introduced into that setting, then it takes off unmitigated, as it did in Wuhan in December, January.
Yep. A number of people, Brett, asking for progress reports on vaccines. I mean, I think a lot of us noticed that the EU has put in an order for 400 million doses for a vaccine that doesn't exist anymore. So is this the equivalent of vaporware, or is there a reason?
Yeah, there's reason to be optimistic in as much as the entire world is focused on this. There are over 120 vaccines under development. Everyone wants it to be developed in the shortest possible time, and they're using really innovative parallel processes to shorten the 5 or 10 years that vaccine development would normally take, including doing the animal, human safety, human efficacy studies almost in parallel, and the manufacturing and production of candidate vaccines without knowing if they're going to be effective, just so that they can have a stock ready should it turn out to be effective. Whether it will be is an open question, but I think the fact that there are more than 10 already at the human phase 1 and 2 trials, and that there are DNA, RNA, protein fragment, synthetic, and all and monoclonal antibody approaches to vaccine development gives us the very best chance of having something that's successful. And it doesn't have to be 100% protective. It might be like a flu vaccine that protects the most vulnerable, that gives 70% protection, that allows us to lift even more.
Okay, so Brett, there are a number of questions about face masks, not surprisingly, and there are a couple that sort of are asking the reason that face masks have been devalued because in fact we didn't have enough in the national stockpile to go around, and therefore the reasons for discouraging face masks weren't about their efficacy but about trying to ensure that there wasn't a toilet paper run on face masks, and the short supply of stocks were prioritised for health workers.
Yeah, I think that was an absolute consideration early on. There were not enough masks for our healthcare workers, and so we needed to get to a point where that guarantee was available to them. They were our front line. They were most at risk. They've been 10% of cases internationally, and so we had to protect them. But the infection control expert group is the one that advises AHPPC, and they're now at a point where they're considering the evidence internationally and locally, and they're still making the recommendation that it's not for widespread use for well people. And I think there isn't strong evidence that it makes a significant difference in a very, very low transmission setting that Australia is now in. I think if we were to get to a point where there's not insignificant community transmission and we're going back to crowded public transport and other crowded settings, then maybe that recommendation will change. But at the moment, that's what I'm hearing from ICEG, that masks are protective, but the utility of them, and we would get through tens of millions per week at a community level if they're single-use masks, are not something to recommend. If it were a 14, 16-ply cloth mask, it's not quite as effective, but that's still, what Public Health England has essentially recommended in the UK, and other places in the US are going with a reusable cloth mask. They're not unreasonable steps for those settings to take.
So, Brett, I've had a question passed on to me by someone who is actually in the medical device industry as a distributor, and pointing out that one of the issues they have in terms of verifying the effectiveness of masks is the loose regulatory system that we have, where the TGA for, as you know, for low-level risk products only requires manufacturer certification that the product is produced according to certain hygiene and manufacturing standards, and therefore they're spending a lot of their time doing their own due diligence as to what now that there are a lot of opportunists in the space producing cheap masks, they're having their own problems in terms of supply to hospitals as to what constitutes medically valid and what constitute simply cosmetic masks. And I've also had pointed out to me that much the same applies with hand sanitizers, all of which aren't equal, but all of which are distributed in a retail environment. And the general public assumes that they're all equally efficacious, and yet without an antiviral agent within them, then they are just alcohol lotion. So is anything being done at that basis? Because I think the general public is assuming that if a mask or a hand sanitizer is available, it must have gone through some sort of stringent analysis of its efficacy.
Yeah, I'm not in the TGA, but I do accept those issues. I'm sure the TGA will reflect on what the standards are for masks and what the assessment process should be at a national level. They did need to go through a rapid kind of approvals process early on in order to ensure adequate supply in Australia. But there will be no doubt reflections on that process, some of the key standards that they will potentially look to enshrine nationally through a certification process. The same for products. If there's not a therapeutic benefit being claimed, then we can all be sold stuff that is less than efficacious and potentially harmful. So that's an intrinsic issue with some of the stuff that's sold that has the appearance of a health product or a protective product that isn't explicitly making the claim and therefore isn't subject to anything other than potential consumer misinformation that might go to consumer affairs. But it doesn't fall under the same regulatory framework as for medicines that are clearly making a therapeutic claim.
Okay, getting lots of questions now. Try to get in limited time through as many as possible. How do we address the limited number of visitors allowed into hospitals? It's a conflicting message for patients to return to treatment, but their support in family members is not allowed.
Yeah, obviously we were very alive to the risk that people in hospital would be to very severe disease, and people with pre-existing conditions and especially already hospitalised are at significant risk. And if there's an outbreak by virtue of it being introduced into a hospital setting where we know that close person-to-person contact has to occur, that's highly problematic. Again, I think we'll go through a review process as we would for prison visits, for aged care visits, for other closed settings, based on the epidemiology that we're at across Australia. And so I think it'll open up over time, it'll be reviewed over time. But that initial constraint was, again, balancing the impossible, knowing that people are supported by their families, by their loved ones in those visits. And so even though it was open for end-of-life care, the constraints were still very significant, and they'll be reviewed. I think we're at a point now where we can open up those constraints in terms of visiting.
So in terms of opening up, there's a question, why hasn't there been a priority on opening up supports and services for those most in need? For example, swimming pool facilities for people who use it for hydrotherapy. The focus seems to be on opening up pubs and sport facilities first, not essential healthcare services.
Yeah, I can't speak for other jurisdictions in terms of the choices they've made, but in Victoria, that's not the case. Everything's been through a public health lens, and it does relate to what the risk of transmission is in those settings, how close people get, high-touch shared surfaces, whether there's exertion, whether it's an indoor or an outdoor setting. They are pure public health considerations that we make. Nonetheless, economic activity is an issue of consideration for Cabinet, and they're part of the decision-making process in every jurisdiction, and they understand what it means for people's overall well-being, health, psychological health, to have economic activity, to sustain their business, to pay the mortgage, and so they are considerations. But I would absolutely say that we haven't gone about it with any bias in favour of economic activity over individual personal well-being.
Okay, we're running out of time, but I'll see if I can squeeze in one or two more. Brett, your view on return to work. I know the public service is not reintroducing this anytime soon, but there's a lot of discussion in organisations, including our own at the moment, as to when's the right time, if there's a right time, notwithstanding the fact that nobody actually seems to want to leave and go back to work.
Look, I think that's an important consideration. I think we will go into a new future where work from home arrangements need to be recognised. There needs to be greater policy flexibility, greater IT and policy support for people to continue to work from home permanently for some people, or permanently part-time for some people. I'm in no rush. In Victoria, there is a consequence of density on public transport, especially for CBD workers in Metro Melbourne. It may be different for rural and regional Victoria, but we should do it by increments, but it does involve hundreds of thousands of people. And so in terms of a cumulative or aggregate risk, that needs to be borne in mind. So I think we'll move by increments, probably beginning in July, but it won't be necessarily back to the status quo pre-COVID. And I think we should try to create that enabling environment for continued work from home for a not insignificant proportion of the population.
Okay, a few questions about the COVID Safe app, largely around the question of has it done any good? I guess I'd add to that a question. We sort of note the fact that there are something like 7 million downloads of the COVID Safe app, but I use the analogy of My Health Record, where there are 22 million individual records in Australia, but only 4% of them have been accessed. Do we have any data that suggests how many of these 7 million apps are actually used, and has it done any good?
Early days, and we're probably at a point in the pandemic in Australia where there's not enough activity for it to have been a game changer. There have been 24 instances of cases since the app's been available in Victoria, where cases have had the app downloaded. But our traditional contact tracing mechanisms, picking up the phone, asking people who their close contacts are, who they've been in a room with for more than 2 hours or 15 minutes face-to-face in the 2 weeks before becoming unwell, captures 95% or more, 100% for many people, of those actual close contacts. And so the app will be useful as we go back to more business as usual, because there'll be more interactions where you're standing next to someone for 15 minutes without knowing their name and their contact details. At the moment, that's constrained. And so most people identify their close contacts as their household and work and family contacts. So it's got some value add at the moment, but it's pretty minimal. But I think it's something that we really need to consider into the future as we go back to the great hurly-burly of busy life in the city.
Okay, so Brett, I've been pulled up by our previous questioner from West Australia who pointed out that the question on travel was intended to relate to interstate, not international travel, and the closing or otherwise between states.
Yeah, look, it's not my place to chime in on other jurisdictions' choices. I think they have to make the same balance about what it would mean to be seeded by a case that's ongoing in Victoria against the constraints that they have for tourism, for economic activity for those jurisdictions. So entirely WA's call, and I wouldn't presume to be able to make those choices for them. The reality is, if you've eliminated it in your jurisdiction, you're going to be appropriately cautious about the potential of seeding into that setting, and a lot of it will depend on how much you've freed up movement and reduced the physical distancing between people. The Northern Territory is almost at a point where there's very little constraint. They wouldn't want the introduction of a case into those settings where dozens and dozens of people who are very difficult to contact trace might occur, the kind of pubs and clubs setting that we're talking about.
Brett, we'll make the next question the last one, even though there are so many more, but we're already over time. Look, someone's asked, are we seeing a growth in health inequity coming out of the pandemic? And I guess I'd add to that, what are we also seeing in terms of deferred diagnosis, screening and treatment for other conditions? We know that ED across the state's down about 40%. So it begs the question, why are people no longer having heart attacks? But how does all this play out, and do you have concerns that death rates from other conditions are going to skyrocket? Absolutely.
I think we've all got significant concerns about what the health equity effects of this pandemic have been. Again, impossible dilemma. These restrictions needed to be in place to stop tens of thousands of deaths, but the impact on health equity has been enormous. We haven't seen it fully play out, but we need to measure it. We need to try and respond to it as best we can. But I think, in many ways, it'll have put us back years in terms of health equity, because it's such a significantly discriminatory thing in terms of how those constraints affect the most the most vulnerable in society. You know, on the issue of, sorry, what was the second part of that question?
The second part of the question was about the drop in screening, diagnosis and treatment for like other conditions, and how we're going to manage that tsunami after health systems go back to some sort of normal.
Yeah, we have to encourage people to attend healthcare as required, and we really need to make that messaging prominent. I've made some videos in support of screening for breast and bowel and cervical cancer, but you know, the routine care through primary care and emergency departments and outpatients, again, we need to promote that. I think it'll be interesting to see exactly how much of an effect there is. We need to bear in mind that there might have been overdiagnosis and overtreatment for some people as well, and there might be benefits from a telephone consultation and less frequent engagement. But again, we need to watch that very closely, and we need to see how it might play out, because you're right, the effects of not getting some routine, especially preventive care, could be very significant.
And finally, do you believe that the current shift towards telehealth is something that we should encourage as a permanent shift? And are there discussions about MBS item numbers and what happens after September?
Yeah, I think there should be a permanent shift that incorporates it as part of the mix. It's clearly not a cure-all in terms of engagement with patients and addressing some particular concerns, health and psychological, but it should be part of the mix. And I think all First Ministers are alive to having it there as an MBS option into the future. So I hope it's there, and I hope it is utilised. I think it's shown that there are some people who have been constrained in accessing primary care because they have to turn up. The costs that are associated with that, both in terms of you know, the travel time, the inability to look after kids at home or whatever else it might be. So I do hope it's part of the mix into the future.
Okay, look, we've got many more questions, but no more time. So Brett, thank you enormously for taking the time to be present today. We did approach a few other medical officers who weren't available, so we really appreciate the fact that you were. I think you can also see from today just how hungry the community is to have the opportunity to be able to ask questions directly. And something that came out very strongly from our first forum, people emphasised the difference between government messaging and communication. And while the messaging's been good, there hasn't been that opportunity previously for communication. So perhaps that's something that can be built into future transactions. You'd certainly be welcome back to future forums, and judging by the amount of questions we've had, we could take the entire forum up simply on a Q&A basis. But lastly, I'd also just like to give you feedback that quite spontaneously there have been a large number of people, particularly Victorians, saying thank you enormously for everything you've done personally, that they hold in high esteem the response that you've managed to deliver in Victoria, and the manner in which that you've been prepared to answer difficult questions, not just here, but in various other media opportunities. And there's a lot of respect and gratitude for what you've been able to do for all of us. So thank you for that, and we hope to have the opportunity of speaking to you again.
Thank you so much, Danny, and thank you everyone for those thanks and for the opportunity again. I would say yes to every opportunity for this kind of engagement. It is really important, and I totally accept that there's a hunger there, and we need to try and respond to it as best we can. And my thanks to everyone, really, because this has been a collective effort in Victoria and across Australia to get us to the point that we're at. So well done, us. Thank you so much.
Thank you. And without further ado, I'm going to go straight into introduction for our next speaker, Professor Jonathan Carnan from